I'd just like to thank the organizers for the opportunity to present this data on behalf of my colleagues. I'm going to discuss type II RAF inhibition of BRAF mutations and truncated fusions in pediatric low-grade glioma. So I have no disclosures. Just to review briefly, BRAF is a member of the RAF kinase family of signal transduction protein kinases. It's involved obviously in MAP kinase and ERK signaling, and to that extent affects cell differentiation and division. BRAF is composed of an N-terminus inhibitory domain and a C-terminus activation domain, whereby the P loop interacts with the A loop through hydrophobic interactions and maintains it in its inactive state until it's phosphorylated. So alterations in BRAF are present in about 75% of pediatric low-grade gliomas, which was mentioned earlier, either as the less common V600E, a mutation, or as the more common KIA 1549 BRAF, truncated fusion duplication. And with the advent of type I inhibitors, which target the V600E mutation, the field of low-grade glioma really saw some incredible responses among patients. Unfortunately, these responses were met with the observation of the unexpected and unprecedented acceleration of tumor growth in children with low-grade glioma, highlighting the paradoxical activation of ERK signaling, which was mentioned in the talk earlier, and really highlighting the fact that not all low-grade gliomas are the same. So to begin to understand these differences, and ideally to develop a drug that would target those mutations harboring the fusion, we developed pathway-relevant models of BRAF mutants. To do this, we used retroviral transduction of the V600E mutation and the fusion into neural progenitor cells. And we did this on the p53 null background in order to actually decrease tumor latency. In an effort to identify compounds and move them efficiently into preclinical testing, we opted to actually make that library of compounds ourselves. Those compounds included agents along the RAF-MEK-ERK pathway. It included type I inhibitors like vemurafenib and dabrafenib, and type II inhibitors like AZ628 and TAC580, which will become important as I move through this talk. And actually, by making them ourselves, we were able to aggregate the need for any MTAA and be able to efficiently move them into testing. So mechanistically, we just need to think about type I inhibition. Type I kinase inhibitors actually recognize their targets in the activated state, and they suppress kinase function by binding to the ATP binding pocket, and thereby suppress MEK activation. So when we looked in vitro, this is in fact what we saw. So in our neurostem cells transduced with the V600E mutation, you saw a decrease in cell viability, and you also saw an inhibition of phospho-ERK signaling. In contrast, for those cells harboring the truncated fusion, you saw a stimulation of cell growth and an activation of ERK signaling in those samples. So type II inhibitors, on the other hand, actually recognize the inactive state of the targeted kinase, and they suppress the function by occupying the ATP binding pocket as well as the adjacent allosteric site. And this basically locks BRAF to MEK and prevents downstream signaling, whether it's in its monomeric form as the V600E mutation or as a dimer in the BRAF 1549 KIA fusion. So again, when we looked in vitro, what we saw was a decrease in cell viability as measured by cell luminescence in those cells transduced with both the V600E mutation or the fusion. And you saw an inhibition of phospho-ERK signaling in both cases as well, highlighting the fact that type II BRAF inhibitors do in fact inhibit both V600E mutants and those harboring the fusion. Usually the next step is to move into in vivo testing, but as mentioned earlier, we don't have any good models of low-grade glioma just to the difficulty in growing them in culture. So to do this, we developed an organoid ex vivo avatar assay direct from patient samples. This actually, when you think about it, is one of the only methods available actually to look at low-grade glioma in its native state. And so to do this, what you do is you take the brains from sacrificed adolescent mice. Those brains are then sliced, they're placed in culture. They're actually sprinkled then with low-grade glioma cells that are harvested during the time of surgery from the operating room on the same day. And you basically then sprinkle them, or rather you co-incubate them with your drug of choice. And so in this case, by day 7 for controls, you can see tumor formation along the paths where you would expect low-grade gliomas to form. In those treated with a type 1 inhibitor, in this case BRAF, you see stimulation of that cell growth compared to controls. And for those treated with a type 2 inhibitor, in this case TAC580, you see an inhibition of that growth. The next question always when you're trying to take something into clinical development is whether or not it penetrates the blood-brain barrier. And to do this, we actually used non-tumor-bearing mice. And again, we use this idea of slice overlays and a method called MALDI. So that stands for matrix-assisted laser desorption ionization mass spectrometry. And what that does is it looks at the spectral peak of your compound in question compared against the backdrop of hemoglobin. And so in this case, you can see that TAC580 diffusely spreads throughout the parenchyma compared to dabrafenib, where you don't see that same effect. And so we had a drug that we knew penetrated the blood-brain barrier. This led finally to the development of a phase 1/02 study. The phase 1 portion of the study is a dose escalation study whereby we will determine maximum tolerated dose or the recommended phase 2 dose with both pharmacodynamic and pharmacokinetic endpoints. The phase 2 portion of the study is a multi-strata study whereby stratum 1 includes patients with recurrent or progressive low-grade gliomas harboring the BRAF KIA 1549 fusion or some such similar fusion. The stratum 2 is restricted to those patients with low-grade glioma in the setting of NF1. And stratum 3 is for patients with recurrent progressive tumors that involve the RAF-RAS-MEK pathway, not eligible for stratum 1 or stratum 2. These patients will receive TAC580 weekly, and that portion of the trial will continue based on tumor response. One of the other interesting portions of this trial is the phase 2 with phase 0 target validation. And so this is for those patients in whom biopsy or resection is clinically indicated, whereby the drug will actually be administered weekly prior to time of surgery, the tumor then resected, and this gives us the opportunity to look for not only brain penetration of the tumor, but on-target effects postoperatively. And the continuation of that portion of the trial is based on whether or not there's presence of the drug in the tumor. And when you think about kind of one of the exciting possibilities for this study is actually to be able to look at resistant mechanisms from pre and post-treatment samples in patients who actually do not respond to therapy. So in summary, BRAF alterations are the most common genomic drivers in pediatric low-grade gliomas. Our current type 1 inhibitors paradoxically activate MEK and ERK signaling in those that harbor BRAF truncations. Type 2 inhibitors do in fact show preclinical and clinical promise for both BRAF mutated and truncated tumors. And lastly, our type 2 inhibitor TAC580, which crosses the blood-brain barrier, really is poised for clinical application in the next upcoming trial. With that, I'd just like to acknowledge our funding sources and, of course, the patients and families without whom we could not do this work. And again, all of the low-grade glioma collaborators that were involved in this project.